So we've got now about 20 minutes for questions. I can see that we got several questions, and I'd like to invite you that if you got further questions to add them. And I'd like to start by bringing up the next one, or rather, the first one. And it's addressed to you, Mirjana. And it starts with, you mentioned using mindfulness to help your client learn to shift his attentional biases away from trauma cues. Would you please be able to expand on this a little bit more, in a bit more detail? I'm interested in what types of activities tend to be appropriate and effective in your experience. Thank you.
With this client, actually, it was very simple. He liked gardening, and he just bought puppies while we were working together. And this was about just using a moment to stay present when he was in his garden, to look at his puppies. And whenever his mind was wondering something else, just to bring it back to the present time. So it can be as simple as that. And this was working for him. He would find himself more and more, staying in that space where puppies were playing. They're innocent. They're living in a moment. They were great teachers for him. So that's one way how mindfulness can be used in a way that is easy for clients to understand and practice at home. It's not about practicing in the room. It's what they take from therapist room back to their environment.
I noticed, Loyola, that you nodding furiously. Anything you'd like to add to that?
Yeah, if we think about Vera that I presented, she hated the idea of formal meditation, but basically I kind of broke it to her gently that her love of walking was kind of a love of a body meditation. And the way that when she was walking, she would notice the world around her. She would sometimes chat, with people on the big road of the Camino Trail, or even in her small walks around her daily world. And so she came to think of and to use and to really value in an extra way the kind of attentional shift and body regulation that the walks were able to provide.
Yes, and frequently when body is hurting, meditation or mindfulness is not bringing them back to their body, is taking them out of themselves and paying that attention without judgment, just observing, just being. And the more they practice, the more they activate left dorsolateral cortex, and that is actually great exercise to improve all three networks: salience and default mode network and even executive network.
I think that's really important, because sometimes that obsessional looping that we see can often be happening in particular people that have a somatizing tendency. And so, like you're saying, to break the kind of looping that they're in neurologically and with their autonomic nervous system by getting their attention out, it's very important.
We'll move on to the next question, which actually, complements this discussion really, really well. It's addressed to you, Loyola, and it reads, how much you use play in your sessions with adults, particularly for clients with significant interpersonal trauma histories who tend to be mistrusting and very cautious to engage.
Yeah, this is such a really important point. And so, Winnicott really got us onto the whole idea about how important it was. And the answer about how you might use play is however I can, really. And oftentimes for very shut down people, it's just in gaze, in speech, in really paying attention. In the conversational model, we'd say we try and pay attention to what's lively or what's most alive. And that might be just a little thing that we notice about the person, how they move, what they say, how they say it. And so it's a tiny little thing that we grow. And then, if they can, then you might start to notice that then somebody brings their own way of playing. And so Vera she loves stories. She's a fantastic raconteur. And so other people, it was very sad. She'd say that other people get very bored by her stories, but I think I found them fascinating. And so she'd bring, her stories, often amusing or interesting, about what was going on. And so that began our play. And I couldn't be just a passive listener. She was very, very, very firm with me that she needed me in there playing too. So the kind of conversation that you'd expect to have with a friend, where they're not just nodding or listening, they're putting in a little bit or being a bit surprised or adding something of themselves so that it's actually truly a game or truly play. That was very important for her, and that's my experience with other people. So the answer is it's very unique, actually, very individual to the therapy. But however you can manage to do it safely, in a way that's appropriate to the kind of therapy you've got going and the kind of conversation is, I think, how one goes about it. Long answer, sorry.
No, that's perfect. We've got another question that from Maskini Shaheen, who thanks you very much for the brilliant presentations you both brought today, but also, you know, this he mentioned, so he that's this is triggered at first for more to learn more about it. And the question addressed to you, Mirjana, is: do you or STATS offer training neurofeedback to other psychologists, clinicians? So would you like to? I know we do, but would you like to tell us a bit more about it?
That's why we established Australian Neurofeedback Institute, ANFI, so that we can provide training and mentoring. And we are just recently got accredited so that we can provide courses that are certified in Australia. So we are first agency that is certified to provide neurofeedback training that can then lead other clinicians to get their certification as neurofeedback providers.
Thank
Fantastic.
Next question reads: I was wondering if you could give an example of repeating trauma or explain what some of the mechanisms that contribute to how this might cause this repetition within a person's life or intergenerationally.
Yeah. Did you want to go with this, Mirjana? We'll probably each have something
Go
to
ahead
say.
and then, yeah.
Look, this is the looping we're talking about, and it can be as simple as in a family that was otherwise okay, there might be a death, you know, that is of maybe the parent of the parent. And then that parent with the new child, the new babe, is having to process the loss online while still being available to the infant or the other children. And it's so powerful. So this is very natural for us to have moments of absorption when we are in grief. But then the child has had an experience of a blanked out face and a disruption in the kind of safety, emotional safety and regulation that they need. And so they themselves, and you know, we might see this in perinatal work, it's very alive in perinatal work, even somebody who really hasn't broken down or repeated much through their childhood, they come to have their baby and they're triggered into a postnatal depression or an anxiety or a little bit of a sort of an almost fugue-like state. So it can be as simple and as small as that, or unfortunately, the story, say, that Mirjana spoke to was where there was a lot of domestic violence. It is highly likely that that was already transgenerationally transmitted. And so, you know, father or other parent is handing that on to the next generation, who hands it on or hands on a reaction to it in the next generation, and so forth and so on. But it's sometimes in that direct behaviour, but it's also in the rather shocking states that a child will experience with a parent. If I want to just give you one example, the woman I mentioned that had such a disturbing reaction to the picture, her mum had a dissociative identity disorder on the basis likely of horrendous childhood sexual abuse. As far as we know, my patient has never been sexually abused, but the horror and the terror and the body reactions that she has are as if she had been. And what she now can sort of put together in her story is that her mother would speak about problems or even bodily functions as though they were sexualized. So her experience was transferred with this sort of infusion of feeling into things that should otherwise be normal. So just to give you an example, my patient talks about having a full ear, you know, a glue ear, a middle ear infection. Actually, it was not a glue ear, it was a middle ear infection. And her mum getting this awful book about her and describing the pressure in a sexualized way. And so, you know, what is a normal bodily sad? It's sickness, right? And it's painful, but it's suffused with something else that comes from mum's experience. And we're not sure, but one can imagine that mum's experience was unfortunately set up by that perpetrator's abuse themselves.
And I believe that we see that in our practice also every day, and many of our clients are, you know, there's multi-generational trauma, grief, loss, never processed. And if you just think growing up where your mother was abused and her mother was abused and there were losses of children, and that is transmitted even non-verbal, it doesn't need to be verbal, especially if it's not processed. When it's not processed, and we see with children that we work with, if something is there in the family, is not processed, is not voiced, often child is the one that will start and bring this in forms of their symptoms that they have, as if, you know, family needs to deal with it. It's not child that is a problem. Child is bringing to us some narrative that is not verbalized there, it's not processed. Trauma is raw, and that's what we see.
Thank you. We'll move on to our next question, which is from Rochelle, and she mentions that she observes this connection from the body with many of her clients with complex trauma. And she wonders whether you could suggest any strategies for helping them to reconnect with the bodily sensations, perhaps using movement in a self-regulating way.
Did you want to start with this, Mirjana, and I'll chip in?
Lloyd, take it. Follow.
I think you can perhaps hear that that was starting in both the therapies that have been talked about in a little bit more detail tonight. That, you know, walking was very important for Vera. That the beautiful way that the aqua class was used, the body connection with the gardening, it seems to me, in the patient that Mirjana presented, the body connection around the play with the puppies, you know, two bodies in safe connection together, that all these things help people start to be able to do it. And sometimes we'll get patients that are very eager, you know, to begin like body scan and be much more conscious and much more active about it. But many of our patients need to come at the body very slowly, very carefully, almost sort of out of a little bit sort of unconsciously. And that's where the unconscious movements that we all have to do around walking. I like what you say, you know, maybe it almost implies like dancing, but anyway, walking that we can do in a very regular daily way can be very important.
Yes, but we're looking at those that have hyperarousal symptoms. Then relaxation and orientation towards body, relaxing body parts can be useful, but those who are disconnected from their bodies, and there is reason why they are, it's usually is not productive. So either body in the space could be the way, but not directly looking inwards, not directly looking at what is hurting there, but they're trying to disconnect. Also grounding techniques, you know, that they can, when you can see that they are going into, that they're dissociating, standing up, firming their muscles, not relaxing, not breathing exercising, slowing down, activate the system. And that's why we also introduced, we have exercises as part of what we do at STARTS. We have aqua classes that is actually quite activating for the body, because that's what they need more than relaxation.
And I love the way that you can sometimes do multiple things. So for example, you might need to get a trauma-informed setting for the activity. So with yoga, some of my patients need to come at it first through a trauma-informed yoga practitioner or class. So things like a mirror is going to be too confronting. A practitioner that might in a normal, say, Iyengar class might touch a student in order to bring about an adjustment. That's going to be a no-no for many of our patients. So they have to be thoughtful and they have to think about it carefully. But the mirror neurons that get activated when they're watching, you know, an instructor or others do the posture are also part of helping there to be a reorganization of the, you know, neurological network. Very important.
And for this client, going to aqua classes was really, it was triggering. It wasn't easy. It wasn't a smooth ride to go out there and it will swim and it will be really nice. It's not. This was Arabic speaking group, all male, all naked. But he was going there with a purpose, and he knew what the purpose is, because he can't avoid triggers his whole life. There are more and more triggers there then. So it's going and then looking at the person who was his personal also instructor that he met before, who is also male, but is there with his smile, with his gaze, with his support. So look at him. If you can't bear to look at everyone else, just look at him, you know, and focus on him. And then focus on breathing. You know, stay present. If you feel that you are hyperventilating, he often did, slow down your breathing. If you're feeling that you're losing, you're disconnecting, then feel you're grounding in the swimming pool, move your hands, move your arms. So yes. all this can help them to actually then, that spreads further. You don't want just this to practice in the safety of your room. When they come, you want them to practice that every day, because they live their life outside, not in this safe therapeutic context. So everything that we can do and think of that they can practice and try at home will help to interrupt this brain, you know, the way how brain got organized around trauma. And with frequent interruptions, they will create new pathways.
And I have to say, although I don't use it certainly with everybody, when somebody's ready, I do use the tapping. And I think that also, you know, is getting a bodily movement going, as well as what it's doing in terms of reorganizing unconscious traumatic memory systems and allowing some installation of different templates. And like Mirjana said, some sort of mantras or, you know, a very different kind of self-conversation.
In neurofeedback, we are lucky. We can touch our client, just their head. But this touch is so therapeutic. And also you can see at the beginning for some of them, just to touch their earlobes, to put sensors, you know, rubbing their earlobes, they're just cringing and just, you try to do it quickly. But then over time, you can see you're almost leaning into your hand, and then they stay just longer up, a little bit more. It's so soothing. The children would do that when they're anxious or scared. And then touching their head gently. That is such a, you know, it is a sacred way of, and safe way of touching someone, holding their back for a little bit. And you can see how much they, later on, they really crave the touch, that safe touch that you can offer.
I'm so glad you said that, because we've got a little bit of experience at the moment with people that are doing our Masters of Trauma-Informed Psychotherapy who are body workers. And so one that's a beautiful physiotherapist talks about exactly what you're talking about, sometimes just holding somebody's head, and the incredible beauty and power of that moment.
And so many wonderful ways in which we can introduce movement and touch, and so many aspects of this therapy. We got 3 minutes left, and we got 3 questions. So let's see if we can address the 3 that are left. I mean, the first one should be fairly easy, and it's addressed to Mirjana. Can you please tell me how many sessions of neurofeedback you would usually perform in your clients?
Mm-hmm. That's a great question, and it's not easy to answer. You know, some clients would need maybe 30, 40 sessions until they're really stable. This client had more than 100 sessions of neurofeedback plus everything else that we did. But depending on the complexity of their presentation, symptoms that they have, and where they are regarding on medication that they take. If they're taking certain medication, it will prolong their treatment. Benzodiazepines, tramadol, that is also opioid. It's not very good when you're working with neurofeedback. So there are many things that you need to think about, and it's, you know, anything between 30, 40, and 100, 150.
And just to complement your answer, Mirjana, at STADS, we not 100%, but we do tend to use neurofeedback with the most complex cases. Let's move on to the next question, which is, does art therapy have a place with and in the support of trauma care? And both of you?
Yes. And if not just art in its, you know, visual sense, but like the patient who had the mum with DID, she discovered singing And so that's been an incredible part of her recovery. And I often feel like her singing teacher is a bit of a co-therapist, actually.
And it's activating vagal nerve, if you think of
So
that.
beautiful. And the chest. And
we have all forms of centray, using art, and then using all sorts of, where you can use your body. We have capoeira classes that are martial art classes, especially good for young people who are, who can benefit not from just to learning social rules and how to behave in a group and to mirror movement or the other person there. Also combat movement, but in a safe environment that actually you're not hurting others. It's a beautiful way of healing, and it's so effective.
Yes. And it's both using art therapy and also art in therapy.
Yeah.
And of course, yeah, dance, body. We've been
Tango.
tango lately. But let's move on to the next question and the last one, which is, I observe this connection from the body with many of my clients with complex trauma. Wait a minute. No, I've lost one.
that might have been me. I put in an answer because it's a comment rather than a question.
Often our clients will approach their body through pain. That's how they've noticed their body. Finding ways of feeling their body, which is around movement, comfort, ease, are also ways and not necessarily directly. Would you like to comment on this?
Yes. Pain, absolutely. And I think that's one of the important things because, as clinicians and as a health system, we have a problematic relationship with pain. We see it as something that must immediately be sorted. And then there's often a countertransferential anger when it isn't, rather than a sign that it's a communication of a body, a person, a system that's under incredible stress. And a way needs to be found into that system, not have the pain just simply silenced. And so I think it's really important that you're saying that. And then it also creates a new narrative for the pain, that it's about a communication, and then a very thoughtful journey has to be undertaken to manage it. We didn't talk much about inflammation today, but inflammation is another one of my very big interests. And those systems, pain and inflammation are so closely entwined.
Yes. And pain is one of the major reasons why clients are referred to neurofeedback program. We are looking at generally clients that we see have more serious symptoms, but two are main areas. One is symptoms of post-traumatic stress, and the other one is pain. And with some types of pain, we can deal with neurofeedback. We can deal with headaches and migraines quite well. And neurofeedback can be quite effective. But there are other sorts of pain that are actually, the way how I'm trying to communicate my internal struggles. And we use that as a way that, that's how body is telling us, pay attention to this. Those who suffered loss, chest pain, it's purely telling, really, it's so much, it's so, my heart is dying. And all sorts of other pains that can help us, bring attention to what body is telling and how body is trying to communicate what is hurting. But then, of course, we have torture survivors, and their pain also could be destruction of locomotor system and really severe injuries to their back. And they need to learn to live with pain. And so that pain doesn't preoccupy their life. We maybe can help to reduce those inflammations around through physio, through other medical assistance, but sometimes they have to live with it. And then I think constructing different narrative.
And I think that key in what you're saying about you formulate, what is the pain and what is the function of the pain. And so, formulate. We're always coming back and then reformulating because the patient has moved. And we've got to catch up. And what's the formulation? What's the story now?
Thank you both so much. This has been an amazing clinical masterclass. Certainly, a great one to finish, the the 5 that we had this year. All fantastic, but this has been absolutely terrific. And I can see that we could go on a lot more with this panel discussion, but it's a bit after 8, so we'll finish now. But let me tell you, if you've enjoyed tonight, that we will start again a cycle of 5 masterclasses next year in 2021. It'd be so good to leave this 2020 behind, wouldn't it? And the first clinical masterclass will be held on March 2021. It will be on refugee trauma and addictive behaviors, clinical work with clients consuming drug and alcohol as a coping mechanism. The keynote speaker will be Professor Catherine Mills, and actually Miriana will also present. I think somebody else was going to initially present today, but Miriana stepped in, and it was terrific that you were able to do that, Miriana. And also, if you enjoyed today, we're actually going to have a full-day workshop with Dr. Loyola McLean on attachment in trauma. And that will be scheduled for the 11th of May and will also be by Zoom. So thank you so much to the two of you. Thank you, all of you, a fantastic audience, and the really good questions that you posed today. It's a great way to finish our clinical masterclasses for this year. Thank you all.